All right. Hey, thanks everybody for joining us today. Heather Hampel is here from the Division of Human Genetics, and she's going to talk to us about cancer genetics. So thanks for joining us today.
Thanks for having me. I understand this is the first one of the year, so we'll dive right into cancer genetics. My objectives for this presentation are just to explain the difference between hereditary and non-hereditary cancers so that you can kind of more readily identify family histories that have characteristics of a hereditary cancer syndrome. Then just the two most common inherited cancer syndromes are hereditary breast ovarian cancer syndrome and Lynch syndrome, so I'll spend a little time on both of those, since they're going to be the ones you're going to see the most frequently in your practice. And then I'll identify some current benefits and limitations of genetic testing for hereditary cancer. It's improved dramatically in the past 3 years, so that even potentially if you referred a patient a few years ago to us and we didn't find anything, it may be worth sending them back because the testing's improved that much. And it might be something that we missed then and can pick up now. So let's just start with the basics. And the good news is that most cancers are not hereditary. And we're really just looking for the small slice of the pie, the 5 to 10% that are hereditary. And you're going to pick up some familial clusters in with those, and they can all come see us in genetics, and we can do the gene testing to figure out who's hereditary and who's not. But the hereditary ones are due to one gene mutation that it causes a strong increased risk for cancer, and that's running in the family. The familial clusters are more a combination of minor genetic influences and environment, making one family slightly more likely to get a cancer than maybe their neighbors, but not a single gene disorder that we can test for at this time. And the vast majority are sporadic, which means they just occurred by chance alone. Age is the greatest risk factor. And these are not something that are going to put their family members at substantially increased risk. So the real key is how do you figure out of all your patients who are giving you family histories or who have a cancer themselves, who's got a potentially hereditary family history. And so the family history is the key to picking out those few patients of yours that do need to see cancer genetics. And so the main clues that we like to say are if you see cancer in 2 or more close relatives on the same side of the family. So a lot of people say, oh, my mom had colon cancer and my dad had colon cancer. There's like a 100% chance I'm going to get colon cancer. That's actually less concerning than if their mom and their maternal grandmother both had colon cancer. 2 cancers on the same side of the family are more likely to be inherited because those people share the same genetics, whereas her mom and dad, assuming they're not related, don't share the same genetics. Big red flag is early age of diagnosis. So certain cancers, breast cancer in women, prostate cancer in men are so common, you're going to see a case or two in virtually every family history you take. But if they're diagnosed in the 70s or later ages, those are less likely to be inherited. So really the red flag should start going off when you hear people diagnosed under age 50. You start to think, gosh, that seems a little early to be by chance alone. Maybe there's a hereditary susceptibility. That kind of plays into the next two, which is if you have a patient who's got bilateral cancer, so impaired organs like the breast, if somebody's had a right breast cancer and a left breast cancer, that's just a sign that they have an underlying susceptibility. All of us can get one cancer during our lifetime. When you start seeing 2, you start having to think maybe there's something going on here, maybe some susceptibility. That also ties into the multiple primary tumors. So whether it's a bilateral breast cancer or one person who's had 2 different primary cancers, those are red flags that it might be hereditary. And certainly with the common syndromes like hereditary breast ovarian cancer, that would be one woman who's had both breast and ovarian cancer, or a woman who's had both colon and uterine cancer would be a big red flag that it might be hereditary. The next one to watch out for are rare cancers, and I wouldn't say you need to see multiple rare cancers in a family. Usually one's enough. And what am I referring to here? Maybe a male breast cancer. That's not a common cancer, and it's usually enough to warrant a referral to see cancer genetics because it's potentially hereditary in that case. And then whenever you take a family history, if you know the family's Ashkenazi Jewish, they have a much higher a priori likelihood of being hereditary than a non-Jewish family. So you'll have a lower threshold of referring your Jewish patients than you do with your non-Jewish patients. This last one, this evidence of autosomal dominant transmission, almost every known hereditary cancer syndrome except one is inherited in an autosomal dominant fashion, which means you're going to see vertical transmission. So you should see like a grandparent, a parent, and then your patient. And so this vertical seal is a sign that it's hereditary. That's much worse than having a couple siblings affected, where it's more of a horizontal pattern. That multiple generation feel is a red flag that it's more likely to be hereditary. Okay, so here's also a cheat sheet sort of thing. So we actually have a tool that's been programmed to this website where you can enter your patient's family history, you can enter your own family history, you can enter anybody's family history, and it will estimate the likelihood that the family is hereditary, both for cancer and for heart disease, which is super useful. So when in doubt, just enter the family history into this tool. If it tells you they're at high risk, that's a family that you want to refer to cancer genetics. If it's moderate risk, they may not need to see us in genetics, but you might need to do some earlier screening. Maybe you start their colonoscopies a little younger, do them a little more frequently. And if they're at average risk, we keep in mind this doesn't take into account lifestyle factors. So if it's a smoker, they have a high risk for lung cancer regardless of their family history. But at least from their family history perspective, they're not hitting any of the criteria. So this keeps you from having to memorize our rather complex and ever-changing set of criteria for when to refer. I think just using the Gestalt kind of criteria from the last slide, this early age, multiple primary, vertical transmission, if you're feeling that, that's enough for referral. Or if you're not sure and you want to plug them in, this will tell you whether or not to refer them or not pretty easily. Just watch the S and the HTTP. It's one of those secure websites. But if you Google Family Healthlink, this is the first thing that comes up, so that's easy. All right, so getting on to the hereditary cancer syndromes. So I always like to start with this slide. And so basically all of the cancer syndromes, if you remember back to tumor suppressor genes, they're all due to tumor suppressor genes. And so these are genes that follow the two-hit hypothesis. And so what you see on the right side of the screen here for the inherited cancers is that if somebody has an inherited cancer syndrome, they've got their 2 copies of each chromosome, and they've inherited one gene that has a mutation in it from their mom or their dad. So that's going to be the orange gene over on the right side. So that one's got a mutation or mistake in it. It doesn't work properly. I'll tell my patients these genes are like the brakes in the car. As long as they're working, the brakes stay on and the cells grow nice and slowly like they're supposed to, dividing when they should and dying when they should. So being born with one mutation does not give you cancer. It gives you an increased risk for getting cancer. And it's only if and when during that person's lifetime they acquire a mistake in their other working copy from their other parent in an at-risk organ that we see a cancer develop. And that's because at that point they've lost both of those tumor suppressor genes. The brakes come off, that cell starts to grow too fast, doesn't die when it should, and that cell becomes the cancer. So people with an inherited cancer syndrome are essentially born one step closer to getting a cancer because of having that one mutation. And that creates all of those criteria that we looked at before. If you're one step closer, it's not going to take as long on average, so you're going to see those earlier ages of diagnosis. Also, if you're one step closer, you can get that second mistake 1 year, have a cancer in your right breast, that's successfully treated. 6 years later, this happens again in the left breast or in the ovary, and you have a whole new primary. And so because that one mutation is everywhere, you're much more likely to end up with multiple primaries during your lifetime. Clustering of certain cancers, and so I think people are pretty aware now, especially with the Angelina Jolie going public about the breast ovarian cancer connection. We're way behind on the colon uterine cancer connection. I don't think many people would be thinking, oh, my dad had colon, my sister had uterine, maybe that's hereditary. So that's one that we have to watch out for our patients, whereas patients are pretty aware of the breast ovarian connection. And then you can see in this, this pedigree or family history on the right, this vertical pattern where the grandma had cancer, the father had cancer, and your patient, the daughter, has cancer. And so you've got that vertical transmission pattern. Versus the left side of the screen, which is most of your families, where she's going to say, oh, my aunt had cancer at 65. And so later age of onset, little or no family history of that cancer, single tumors or unilateral tumors, no vertical transmission. These people are born with all those cancer susceptibility genes working just fine. You're aging, you're acquiring mutations. If any one cell gets enough of them, and age is our greatest risk factor here, that cell can become a cancer. But these aren't mutations the person was born with, so they can't pass them on, and so these are sporadic cancers, and that, luckily, is the majority. All right, so dominant inheritance you all know, but if your mom or dad have one of these mutations, which is the capital A in this little diagram, you have a 50% chance that you're going to inherit that mutation, and you likewise have a 50% chance that you are not going to inherit that mutation. And so I think one of the things that we find that's interesting is that if you're from a family like this and you ask someone what they think their risk is for getting cancer, they'll often tell you 100%. And so sometimes it's actually good news to them when you find out that, in fact, it is hereditary, but there's only a 50% chance you've inherited the mutation that's causing the cancer in the family. And even if you did inherit the mutation that's causing the cancer in the family, as you'll see in a minute, this isn't complete penetrance, so the cancer risks aren't 100%. So we occasionally find a nice 100-year-old lady who's had a cancer gene mutation her whole life, never got the second mutation, never got a cancer. So letting them know that this is not a definitive, and that even in the highest risk scenario, there's only a 50% chance that they've inherited is important. And this is where it's really critical for you as you're trying to decide, does this person need breast MRI or can they start mammograms at 40? And so the issue is if their mom or dad has a BRCA mutation, we want to find that out, and we want to test your patient and say either, yes, you do have this mutation and you need to start MRIs at 25, or no, you don't, and you're actually back to the general population risk. And so we can get a patient back to the general population risk if we prove that their family has a mutation that they did not inherit. This is also why we like to test the affected family member first, and this bothers patients. It drives them crazy. So you'll send an unaffected patient over to see us in genetics, and we'll say, wow, your family history does look really alarming, but I'd like to test Aunt Patty, who had breast cancer, first. Because my patient's unaffected, so even if there is a mutation in the family, she's only sitting at 50% risk. So if I test her and she's negative, I don't know that there was a mutation that she didn't get, which is a true negative. Or if, in fact, this whole family is negative, we haven't found the right gene yet, there's still something going on here, and she's potentially still at increased risk. So we like to up our odds of finding the mutation by testing one of the affected family members. And if I have lots of affected family members still living, which I don't always have, then we go for the earliest onset, or the one with multiple primaries. You pick your person that's most likely to test positive. This used to be a bigger deal when testing was super expensive, when we had to do one gene at a time. Now that testing's gotten a lot easier and less expensive, we're a little more likely to let that unaffected family member go ahead and test. We do our nice fishing expedition, and we tell her, listen, if you test negative, you really need to try and get Aunt Patty to come in. But if she's positive, we have an answer because we know, yes, it's hereditary and this is the mutation. So we used to turn away those unaffected and try and get the affected in first. Now we're a little bit more likely to actually test them, but let them know if they're negative, track down Aunt Patty. So that's kind of that, and that's the reason you might have heard a patient you refer come back and say, well, geez, they want me to get my cousin, and she's in Texas, and we haven't talked in 10 years. And Facebook actually, ironically, has helped a lot with this, too. It's amazing how many people, you probably see it in your practice, can find out quick medical and family history information on Facebook, even in the hour of my appointment, that they weren't able to get before. Now, 2 specific syndromes I want to cover today because they're the most common, and if you got these down, you'll catch most of the hereditary stuff coming through your clinic. Hereditary breast ovarian cancer syndrome. The general public's risk for cancers are on the left column, and then for a BRCA1 mutation carrier or a BRCA2 mutation carrier on the right. Important things here are the second primary breast cancer risk row, the second row. For this reason, because there's a much higher second primary risk, a lot of newly diagnosed breast cancer patients come to see us very quickly to figure out if they have a mutation or not before they elect whether to do bilateral mastectomies or unilateral mastectomy or just a lumpectomy. If they're hereditary and looking at these very high 20 to 60% second primary breast cancer risks, they're much more inclined to do a bilateral mastectomy. So we hold urgent surgical decision-making appointments open weekly, and if you've got a newly diagnosed breast cancer patient in your clinic, we can get them in and get them tested before they make a decision about surgery so that they can make a surgery decision knowing whether or not they're looking at these higher second primary risks. So that's really important. And then the ovarian cancer risks are quite elevated here, and this is a concerning cancer because we can't screen for it effectively. And as you'll see in a minute, the recommendation is actually risk-reducing bilateral salpingo oophorectomy at this point because we don't have an effective screening there. Male breast cancer risk is elevated, and certainly more with BRCA2 than BRCA1. It's a little controversial whether to try a mammogram in this population. It kind of depends on how much breast tissue they have, but certainly a clinical breast exam can be really important there. Increasingly, these two genes and their link with pancreatic cancer has been becoming interesting. If you have a family with 2 or 3 cases of pancreatic cancer, there's actually a 12 to 17% chance it's due to a BRCA2 mutation, even if there's not a single breast or ovarian cancer in the family. It's the #1 cause of familial pancreatic cancer. And so I think a lot of people don't realize that, and we can now see those patients and get them tested. Another scary cancer for which there's not great screening. Prostate cancer, this elevated risk is interesting, and there was a paper last summer which basically implied that, found that 14% of metastatic prostate cancer cases are hereditary. So you only find 4% if you take all prostate, but if you take your metastatic prostate cancers, so in other words, these hereditary ones must be more aggressive, that there is a higher risk. And so now there's some momentum behind referring all of your metastatic prostate cancer cases, all of them regardless of family history. Also because some of these mutations can change their cancer treatment, and so that can give them new therapeutic options. The surveillance for breast cancer and risk reduction is just good breast awareness, aka self-breast exams, even though those aren't on most people's radars anymore. Clinical breast exams every 6 to 12 months, starting at age 25, or 5 to 10 years before the earliest diagnosis in the family. And we'll often tell them to alternate between their GYN, their PCP, if they're seeing a breast surgeon, the more the better, because what one might miss, the other might catch. Then this is a change recently. We actually start MRIs first at age 25 through 29. They wanted to delay the radiation exposure from the mammogram as long as possible in those young breasts. And so they start with the MRI annually from 25 to 29, add in the mammogram at 30 now, essentially every 6 months. And so they're getting great imaging throughout the year, and what you might pick up an interval cancer there by going every 6 months. Once they reach age 75, it's kind of considered on a case-by-case basis, depending on other comorbidities. Some people say if you would treat the cancer if they were diagnosed, then they're probably healthy enough that you should continue screening them. Chemo prevention, not popular with anyone, even this high-risk population, but tamoxifen is effective. And many people, and much more recently than in the past, are electing to do prophylactic mastectomy, perhaps because of the Angelina Jolie effect. And certainly that's going to be the most significant risk reduction. For ovarian cancer, we are recommending risk-reducing bilateral salpingo oophorectomy between ages 35 and 40, assuming that they're done with childbearing at that point. And they do need to do the surgery slightly differently than an ordinary hysterectomy in BSO. They actually serial section the ovaries and tubes every 2 millimeters to look for occult primaries. And so if patients will ask, can my regular OB/GYN do this? Yes, of course, but they need to make sure they're going to talk to pathology and get that serial sectioning done, because normally they just bivalve the ovaries, and that's not going to be close enough of a look. There's almost as high as a 15% occult primary diagnosis rate in these ovaries. Also, they do pelvic washings, so peritoneal washings, which wouldn't ordinarily be done, are done in these cases. If the patient's going to delay their oophorectomy, then they can try screening even though it doesn't actually work, and that would be a transvaginal ultrasound with color Doppler beginning around age 30 to 35 and adding a CA-125. But lots of studies on this, none of them look good. Oral contraception actually does decrease the ovarian cancer risk, but some people try to avoid it because of the slight increase in breast cancer risk. Other people say, well, the breast cancer risk is pretty manageable, so maybe getting that decrease in ovarian cancer risk is a good thing. We certainly don't put people on oral contraceptives or suggest that they talk to their doctors about going on just to reduce their ovarian cancer risk, but I think the bottom line is it's fine for them to take them if they need them for other reasons, and they'll get a little benefit. It looks like at 5 or 6 years use, it drops their ovarian cancer risk pretty significantly, at least up to 50%. That's pretty good. This is a family history of a classic BRCA mutation family, and just to note that this can be inherited from the father. She inherited this mutation from her dad, who had prostate cancer at 58. And in fact, the referral criteria for NCCN now say if you have 3 cases of breast, ovarian, pancreatic, or Gleason grade 7 or higher prostate cancer, that's enough for a referral for cancer genetics. So add the prostate, the high grade ones, and the pancreatic into your sort of differential. And then they went to make this one tricky and put a skip in so that we would call that a non-penetrant grandma. So the grandma apparently had a mutation, lived to 83, and never got cancer, but if you dig a little further, there's a great aunt with ovarian and a great grandma with breast at young ages, and so this is a BRCA mutation family. And they're just trying to point out some common misconceptions. So there's a lot of people who think you don't need to worry about breast and ovarian cancer if it's on the dad's side of the family. That is not true. Half of all women with BRCA1 or 2 mutation have inherited it from their father, and that can hide a family history. Say if the dad only had one brother who's going to get an ovarian cancer and there's very little breast cancer risk, so there's not much family history, and it can make it much more challenging to pick up these families. Ovarian cancer is absolutely a risk factor in breast ovarian cancer risk. In fact, because it's a more rare cancer, adding a single case of ovarian cancer to a family history with some breast cancer really ups the odds that they're going to test positive, because breast cancer is super common, so you can see a couple cases by chance alone, but you add that ovarian and it's much more likely to be hereditary. Then the other thing, and this is going to drive your patients crazy, they always feel like the number of cases of breast cancer in their family is the most important, even if all 3 of them were diagnosed at 75. And that's actually very unlikely to be hereditary, even if there's 3 cases of breast cancer, if they're all at 75. 1 case at 32 is much more likely to be hereditary than 3 cases at 75 because of that just late age of onset, and that 1 in 8 of us will get a breast cancer in our lifetime. Okay, so switching to Lynch syndrome, my favorite syndrome, so this is where I do my research. The general public's risk for colon and endometrial, stomach, and ovarian cancer on the left, and then you can see the risk with the various, there are 4 different genes that can cause Lynch syndrome. And I think the thing I want to point out here is 2 things. One is, look how low the cancer risks are with MSH6 and PMS2. These families can really hide in your clinic. They don't look like the classic slam dunk Lynch syndrome family. I would even miss them. They really don't often have a ton of cancers. The second thing I want to point out is that MLH1 and MSH2 ovarian cancer risk is up to 24%. That's almost as high as the ovarian cancer risk with BRCA2, which was 27%. Historically, we've never thought Lynch syndrome when we saw a couple of ovarian cancers in the family, but we really need to, because it could absolutely be Lynch syndrome where we've just seen a predominance of ovarian cancers. So I think those are the 2 notable things here. But suffice to say, these are the 4 most common cancers with Lynch syndrome. The screening, if they're positive, is colonoscopy every 1 to 2 years, beginning at age 20 to 25. Or 2 to 5 years younger than the earliest diagnosis in the family. So I have a Lynch syndrome family where my youngest diagnosis is a 19-year-old. So unfortunately for that family, we're starting their colonoscopies at 14. But generally, this starts 20 to 25 unless you've had a really unusually early diagnosis. If that patient with Lynch syndrome gets a cancer or multiple or an unresectable polyp and they're going in anyway, they usually recommend doing a subtotal colectomy instead of a segmental resection, because they do have such a high risk for 2nd primaries and 3rd primaries. With the uterine cancer, increased risk, you can do transvaginal ultrasounds and endometrial aspirates starting at age 30 to 35, but again here we're seeing most of our females with Lynch syndrome just consider a TAH-BSO after childbearing, eliminates 2 of their top 4 cancers. And here we don't see, with HBOC or hereditary breast ovarian cancer, you can see a risk for primary peritoneal cancers even once the ovaries are gone. You don't see that with Lynch. Once the ovaries and uterus are gone, you don't see very many of the gynecologic cancers at all. So it's very effective. And the colonoscopy should be able to prevent their colon cancers too. So this is very preventable cancers. We just need to get these people diagnosed so they can get on these screening regimens. We can't ethically randomize people to screening or not screening, but what they did in Finland is they told people that had Lynch syndrome that based on their nationalized medicine that they should get a colonoscopy every 3 years. And they waited 15 years and saw what happened. And they randomized themselves, which is what you see in your own patient clinic, right? Half of them will go do their colonoscopy and about half won't, no matter what you try and do. So here you can see what happened. So the group that was not doing their screening, there were 12% of them got a colon cancer. And the group that was going every 3 years, 4.5% got a colon cancer. So we saw a 65% reduction in colon cancer incidence by going every 3 years. This is why we're recommending every 1 to 2, because we don't want to see those 4% that we're seeing here. But what's really important, and it's not on this slide, is half the people with colon cancer in the group that was not screening died from their disease. Nobody in the group going every 3 years died of their colon cancer. They were caught early and they survived their cancer. And so we know even going every 3 is going to lower their incidence of cancer, and they will not die from their colon cancer. So every 1 to 2 should be our sweet spot there. Here's a classic Lynch syndrome family. They don't all look like this. If they did, we would not have any trouble identifying them and referring them. But you see multiple generations, some people diagnosed under 50. You can see an ovarian and an endometrial along with a bunch of colon cancers. So if they look like this, they'd be pretty easy to pick up, but they don't always. So what's happening with genetic testing? So we have this new technology called next generation sequencing. And what we used to do was Sanger sequencing. With Sanger sequencing, you literally had to do one gene at a time, and it was about $1,000 a pop. And if that one was negative, you'd try the next one, and it was tedious, and you really had to pick the right genes and test in the right order and pick the right patient. This way, we can do multiple cancer genes at the same time for a much lower cost. I have a panel that has 79 cancer genes on it. The whole test list price is $1,500. For frame of reference, BRCA1 and 2 alone, before Myriad lost the patent, just for those 2 genes was $4,500. So we're a third of the cost now that they've lost the patent on BRCA1 and now in 40 times more genes. So testing's changed quite a bit. So one thing I want to tell you about the test being higher quality. Back in the past, if you referred to me and we did BRCA1 and 2 on your patient, they got sequencing only. And then they've said, oh, well, if you're worried about there being a large rearrangement in the gene, that's an extra $750, which insurance never paid because they said, hey, we just paid $4,000 to test those genes. Why do you want another $750? So many, many people who saw us only got sequencing. And they could be walking around with a BRCA1 or 2 mutation, and we told them this, they're aware, but they could not afford to do the extra test. All of the testing now includes both sequencing and large rearrangements. And so if you have a family history you don't like who saw us and was negative in the past, send them back in, and we'll make sure to get large rearrangements. The other thing is they include a lot of new genes that we couldn't test for back then because the odds of picking them up were so low it wasn't worth it at $1,000 a pop. But when you can just throw them on a panel, why the heck not? So my examples, there's a gene called PALB2, which I remember as the pal of BRCA2, but it's literally the partner and localizer of BRCA2. If you have a mutation in that gene, your family history looks just like a BRCA2 family because it works directly with BRCA2. And I was seeing a patient, actually his wife was there, and she said, well, I have this horrible family history of breast cancer, but don't worry, I had gene testing and I was negative. And I said, oh, really, when? And she said, a few years ago at the Cleveland Clinic. And I said, what did they test you for? And she said, just BRCA1 and 2. And I said, well, I'm a little concerned. Your family history sounds pretty significant to me, and there's this new test and more genes. We ended up testing both the husband and the wife. He was negative. She did have a PALB2 mutation she didn't know about, and she's done prophylactic oophorectomy since then. So a lot of new genes which look just like BRCA1 and 2, other colon cancer genes that we can test for now. And surprisingly, the cost went down. And so you heard about the difference between BRCA1 and 2. Here's how the insurance works out. If you have third-party insurance and you meet testing criteria, you're almost always looking at $100 out-of-pocket max or less. If you have Medicare and you meet their testing criteria, you owe $0. And the testing criteria are the obvious things, like a couple cases, one diagnosed under 50. Insured patients or Medicare patients who don't meet their testing criteria can now pay out of pocket, and there's patient pay prices at 2 of my labs as low as $249. You can get a 31 cancer gene panel, pay out of pocket $249. They don't even bill the insurance. And it's a good test. And my favorite lab is $475 out of pocket. So oftentimes, if you send a metastatic prostate cancer patient to me, Medicare doesn't have criteria right now they haven't caught up with the paper from June. So I can't often get them covered under criteria, but they can just pay out of pocket, and that's a reasonable amount out of pocket, and get those genes tested. And the 31 genes include BRCA1, 2, all the Lynch genes, the PALB2 gene. If a patient of yours is underinsured, Medicaid, the Medicaid's not showing. Medicaid is if you make less than 4 times the federal poverty limit, which is very generous. Basically, anyone on Medicaid qualifies. We apply for their hardship program, and their test is free. So I can get your Medicaid patients tested too. So it's these uninsured, well, that's where they are. They fit in this uninsured and underinsured too. So same with Medicaid. They have no cost if they make less than 4 times the federal poverty limit, which anyone on Medicaid does by definition. So testing, I can get your patients tested now. That's not a problem anymore. When should you consider it? Patients with a significant family history, reasonable likelihood of having a mutation. Again, we like to start with an affected family member if we can, but if we can't, no problem now with these panels. If the results are going to change their management, so they're going to choose a bilateral mastectomy instead of a unilateral, they want the information. They were negative in the past, but you don't like their family history, send them back. We'll do the genetic counseling, and we prefer to do testing here in combination with genetic counseling because we can discuss things like insurance discrimination and other risks of doing testing. And also we can talk about the implications of testing before they get the results back and not after. So what are the insurance issues? So since 2009, there's a federal law in effect called GINA, the Genetic Information Non-Discrimination Act, that says that your patient cannot be discriminated against in health insurance or employment based on genetic test results. So this was one of the major barriers to testing in the early years. People thought they'd lose their insurance or get charged higher rates. There is now law in place protecting them in all 50 states. There are some loopholes, and the main one that we talk to patients about is it does not protect life insurance, disability insurance, or long-term care insurance. Most people aren't as worried about long-term care and disability, but life insurance is something that you often want to have, especially while you have small children. And the group that's the most susceptible to not having this and not caring about it is when I start testing 18 to sort of 25-year-olds. They don't have life insurance. They don't care about life insurance. So we have this discussion. I have had some parents who pick up a life insurance policy on these kids before they get their testing, because once you have one in place, you're a lot less likely to lose it. And others who are like, well, there's no documented cases of anyone being discriminated against in life insurance at this point, so we'll take our chances. If they apply to one that asks a question along these lines, we'll apply to a different company. So patients have a different level of concern about this issue and handle it in different ways, but it's good to have discussed it with them instead of finding out afterwards, oh, my 18-year-old did gene testing and she's positive and now she got turned down for life insurance or something like that happened. Okay, so take-home messages, and I'm late, is that all cancer is genetic, but not all cancer is hereditary. Taking a family history and updating it regularly is going to be critical for you guys to identify these families. When you're doing your risk assessment, age of diagnosis is more important than the number of cases. Ancestry is critical. Rare tumors make a bigger impact. And if you identify these high-risk families, it allows for consideration of testing, tailored cancer surveillance recommendation, and potentially a change in their actual cancer treatment. So it can be quite useful. Thank you.
Marvelous. That was a lot of information.
Whirlwind.
Really well organized. Well, let's go ahead and open up to questions. I'm going to go ahead and unmute everybody's phones. Does anybody here have any questions?
Is there any discussion of integrating this calculator into IHIS?
We have been talking about doing some things with IHIS. There was for a short while, I'm not sure if it's still in, what do they call them, a BPA for a certain family history of breast cancer, for better or worse. So I think sometimes we all get BPA alert. I know I get the flu shot one and I can't even give a flu shot, so I'm like, stop, go away. But it wasn't working great. So in other words, one of the criteria was 3 cases, and it would count both sides of the family instead of just one side of the family. So even our breast surgeon who works in genetics, Doreen Agnes, would get the flag and say, what? And she'd look back at the family history and say, why did this family get the red flag? I wouldn't refer them. So it wasn't perfect. It was better than nothing. But it would be nice to integrate a better tool, and there is a lot of activity towards this nationally. We've had a little trouble customizing the OSU version of that because they're very averse to tailoring anything that might make updates challenging. So we'll see, but it would be great. It would be great. Even one group I'm working with now is like, I'd like to know even if they just need increased screening. Maybe if they need to start their colonoscopies 10 years younger and go every 5 years, it would be sure nice. I'd put that family history and it should be able to tell me that. So we're working on it.
So for newly diagnosed breast cancer, I don't see everybody gets tested for BRCA-mutation, I think, right? Unless there is a strong family history.
Yeah, so if they're under 45, so this is newly diagnosed breast cancer patient, does everyone come get BRCA1 and 2 testing? Not yet. So if they're under 45, that's enough, even with no family history. If they're triple negative, it's actually enough even if they're under 60. So if you happen to hear they're a triple negative, so ER, PR, and HER2 newer negative, that's so much more likely to be a BRCA1 case that the current NCCN guidelines say recommend them even if they're under 60 and have no family history. Beyond that, you need a little family history, so some additional breast or ovarian cancer. But those 2 things on their own, so if they're under 45 or under 60 and a triple negative, it's enough on its own. Otherwise, you're going to need a little bit more family history. Now, contrast that, current recommendations every single ovarian cancer patient should receive genetic testing. We had a little trouble. They would get referred and they're so darn sick. They didn't want to come for another visit at a different location. So we've actually now integrated at Mill Run and Gynoc, one of our counselors. So she's getting a lot better yield that way from just physically being where they are anyway. Understandably, they were sick. They didn't want another appointment on a different day in a different location. So we've been trying to get a lot better at integrating. We have cancer genetic counseling at the Breast Center, at Mill Run, and then in the tower here at Morehouse. So we're at a lot of the places where the cancer patients are getting treated at OSU, which makes it easier on them.
Other questions?
I have one quick question that I know probably doesn't have an answer. This is Sarah Jonas. I have a number of patients who are adopted, so we have absolutely no family history on them. Do you have any recommendations for how we manage that?
That's been a real challenge because telling them we have to wait until they get a cancer to worry about it is not a really answer that they like to hear.
Right.
And I think with these panels, we're going to see a shift. So they're even talking now about having a wellness panel on Invitae that includes kind of the common adult onset diseases, not just cancer, but also cardiovascular disease. How do you know they're not walking around at risk for dilated hypertrophic cardiomyopathy? So I think they're going to pick some of the common adult onset stuff. It's probably going to be a pay out of pocket situation because insurance isn't going to cover it if they're not meeting certain family history criteria. However, when you're looking at patient pay prices like I was showing you, $249 or $475, I have a lot of adopted patients that would be willing to do that because they don't know what their family history is and what they're at risk for, and that's not really fair to them. Historically, we've said, oh, you know, if something happens to you, then we'll know what to test you for, but that's not a really fulfilling answer for these patients at all. So I think they're going to be able to get, and in fact, I could order a panel on them now, but I think I'd almost wait till I have a nice panel that includes more than just cancer because we should be equally worried about potentially a hereditary heart disease. The American College of Medical Genetics has a list of 56 diseases that sort of you would take action. There's something you could do about it if you tested positive, like implanting an ICD or something like this for a heart disease. Probably those are going to be the 56 we're going to see on this wellness panel, where you could also see your worried well patients who are, well, you know, you've all got some of these patients in your clinic. I'll say no more. But they've got a lot of resources and they're worried well, and so that would be a nice panel for that group as well.
Awesome. Thank you.
So I have a quick question before we wrap up. So your patient is the one in front of you, but could one say their children are your patients too? And how does that, because you're then making a decision on behalf of your children in a way, aren't you?
Yeah, so I mean, in genetics, my patient is the family. I think of the whole family as my patient, which is a very different way of thinking than ordinarily. And I think that's one of the reasons why doing genetic testing in the genetics clinic is so nice, because once we get that positive, we go out of our way to get all of their at-risk brothers and sisters tested, sons and daughters. We'll figure out if it's from mom or dad's side of the family. Then we'll start tracking down aunts and uncles and cousins. And these are people that are probably not in your clinic that you don't see. How would you have any access to them? But yeah, you do need to think of your patient. We'll have patients that this isn't going to change anything for them. They're dying of pancreatic cancer. But gosh, if we wait till they've passed away and their daughter comes in worried, we're going to sure wish we had seen that pancreatic cancer patient before they died. So it may not change their personal management, but they've got at-risk children or siblings who it can definitely change the management of. And a lot of times, too, they want to do something to help their relatives, and so it gives them something concrete they can do when so many things are out of their hands at that point. But yes, definitely try to think of the other at-risk people because it may not be the patient that it helps at all, and
right.
It may be their relatives.
At the time of death, I mean, we have conversations about donations and things, you know, but is there a conversation about genetic testing at the time of death?
Not routinely, although we've just heard that Schrödinger here in town offers a DNA banking service as one of the perks on their funeral services.
Okay,
we haven't actually tried testing from that bank DNA and don't know if it's banked properly or not. We'll get calls, and unfortunately, very quickly after the person dies, that blood starts becoming non-testable because it clots up. But you can actually occasionally get a fibroblast skin biopsy. This is usually not such an issue on my cancer patients, but with sudden cardiac death, this can be a huge issue. And that may be your only person to test. And so they've done skin punch biopsies post-mortem. Autopsy pathologists here at OSU actually have some training in cardiac and cancer genetics, and they will make a recommendation on autopsy reports to families and take a couple tubes of blood and stick them in their freezer if it looks highly likely to be hereditary, because you may miss your chance. with cancer, there's usually another affected in the family, and you should have several months where you could have gotten them referred and seen, but sudden cardiac death can be real challenging.
Yeah. You know, I did something a couple of years, about a year and a half ago. I just did a search in Epic through my whole patient panel and said, find all my patients with ovarian cancer, and then find all my patients with breast cancer and their family history, either them or their family history, and then just went at each one and sort of asked those questions that you asked in your slide.
Cool idea.
I ended up referring 2 people to genetics, and, you know, it's sort of like something that's available for all of us to do. Obviously, the time is the issue, right?
Yeah.
But I don't know that time should be a barrier, especially as we transition to different sort of payment models where it's not all visits. You would think interventions like that could have a huge impact, especially when you do them at a scale where, I mean, we manage 60,000 patients across our division, and, you know.
Oh, it's such a great idea. Think of a research study, too. If we have a resident or fellow who's interested in, you know, even writing up what percent needed referral or met criteria, if you could do did you use answers? Like IHIS?
No, just right out of IHIS.
Just right out of IHIS.
Yeah.
That's cool. You're better at IHIS than I am.
That's why saving and storing the correct information creates. But I mean, the point is, if you store the information correctly, it creates opportunities in the future that you may not even realize. Absolutely. That you may be missing.
Absolutely. So. To that end, I'm not a big fan of when people put breast cancer in and then the name says negative history, because then breast cancer comes up when you query that, and they can even set off BPAs and stuff. But I think in the new family history, they've got ways to indicate negative family history. It keeps getting better.
Yeah. Well, hey, I really appreciate you coming by. I think we all profited from this talk tremendously. So thank you again.
Thanks, guys.
Thanks, everybody.
Thanks for all the time you put into organizing this.
I do.
Very wonderful.
Thank you, guys.
Where did I lose my recorder?
I don't know.
It's usually down here.
Do the stop share. Oh, to stop the recording.
Down here somewhere. Well, I shrunk it down to the bottom of the screen.
There it was.
You see it?
Yeah,
Yeah,
up there.
way
Oh, there it is.